My name is Michael Bailett, and I'm going to share some information that will hopefully help inform the work that you are undertaking. And so let me proceed. I'm going to start by reviewing an analysis that we did for an initiative called Buying Value. I'll explain what that is, looking at the different state measure sets that are in use across the country. I'm going to share our organization's direct experience working with 4 different states on developing core measure sets for different uses. And then third, I want to suggest some key policy decisions that I think you'll want to ponder as you think about developing an ACO core measure set, and then finally suggest some steps that you might want to take along the measure selection trail. So first, I want to talk about the buying value study. Just a minute on buying value. It's employer-led project, or employer and labor-led project to speed adoption of value-based purchasing, and they focus on performance measures because they believe it's fundamental, it's foundational for value-based purchasing. And so they convened a group to try to promote measure alignment, and they wanted to do so across both private and public sectors, and wanted to get a glimpse to see how much alignment or non-alignment was there in quality measure sets in the present day. Why they want to look at this? Well, measure misalignment creates what I'm referring to here as measure chaos for providers because they get subject to multiple measure sets, and those measure sets represent different accountability expectations frequently and increasingly with financial implications. So I've had the experience in different states across the country of having people say to me, or physicians say, this is crazy, I'm subject to 77 measures, I'm accountable for 234 measures, I'm responsible for over 300 measures. And these mixed signals to the market make it difficult for provider organizations to focus their quality improvement efforts. And so, no surprise, leads them to tune out both some payers and some measures because they conclude they can't do it all. So that was the rationale for buying value, wanting to bring focus to this. So they commissioned from us a study to look at alignment of state-sponsored measure sets. And so we gathered 48 of these. The measure sets were developed for different purposes, ACOs, medical homes, Medicaid managed care, for health insurance exchanges, sometimes just for reporting, sometimes for payment. So anyhow, multiple uses, but 48 measure sets from 25 states, and also 3 regional collaboratives. So not quite 100% state measure sets, but almost all of them are. Here are the states from which we gathered them. We looked particularly deeply at 2 states because buying value was interested in seeing whether there's alignment within states, if not across states. So that's why we have more measure sets from California and Massachusetts. You'll note that there are 2 measure sets listed here from Maine, and these are the 2 measure sets that were gathered. This effort was not all-inclusive, so there are measure sets from both the studied states and from the states that we didn't study that were not included, but we wanted to have something that was broadly representative, and hence the 48. We were shooting for 50, came up too short. So I want to share some of the results from the study. First, we found that the measure sets varied in terms of their size from 3 to 108. The average was 29 measures. And so the measure sets tended to be fairly large. What we found was that there were almost 1,400 measures. And of those, 509 were distinct. And by that I mean that there were a lot of measures that were very closely related to one another, but they changed a time period or they modified the denominator, but in many cases it was essentially the same measure. So lots of modification of measures for special purpose. Only 20% of the distinct measures were used used by more than one program. So very little alignment observed in this study. And the non-alignment occurred despite the fact that most measure sets were using standard measures. And when I say standard measures, I mean most of them were MQF endorsed, and a large percentage of them were HEDIS measures. So let me dig into this a little bit further. The measures were distributed across a number of different measure domains. These are the domains that we used. I think we took them from NQF rubric. States mostly are using standard measures, although not at all exclusively. You can see there are a number of modified measures. There are homegrown measures that they made up. 6% we couldn't tell where they came from, and the other 3% were either bundles or composites of standard measures. There was a heavy preference for using HEDIS measures. They were sometimes modified, but HEDIS was the most commonly selected measure set. Of the distinct measures, however, only 16% came from HEDIS. So there's a small number of HEDIS measures that are being used over and over again, but never the same combination. Meaning people they select different HEDIS measures, and I've got a little graphic to show you that in a minute. So very little sharing of measures across measure sets. And in fact, only 19 measures were shared by at least a third of the measure sets. The measures that were most frequently used are found in these categories. But again, most frequently used doesn't mean that there's a lot of common use of the measures, but where there was common use, these were the measures. You can see lots of diabetes and cancer screening, the most commonly used measures. So this is how we visually have depicted what's going on with the measures. They're drawing from standardized measures. They're drawing a lot from HEDIS, but they're picking different ones. And so breast cancer screening was the most frequently used measures, and yet it was only used in 63% of the programs. And the ironic thing here is that breast cancer screening measure is no longer aligned with clinical guidelines, and that was the most commonly used measure of the measure sets we looked at. Regardless of how we cut the data, what we looked at by program type, so is it just for medical homes, program purpose, the domain, within states, we just didn't see a lot of alignment.
We've got these slides, we'll distribute them afterwards.
So is that a question or comment?
No, that's it, Michael.
Okay. What we concluded is the measure sets that have been developed to date have been developed without an objective of trying to align with other measure sets. And it's natural that we have so much variation because the pool of available measures is quite large now. I remember early on in my career, I participated on the committee that developed what became HEDIS 1.0. And prior to that effort, there were no standardized measures that were used. Well, now we have many choices, and people select the measures that are of greatest interest to them based on a number of different criteria. Even if people want to try to align, there aren't really good tools to help them do so. And it's unlikely that we're going to get alignment unless that becomes an overriding goal for measure set developers. And in our work with states, quite clearly there are a couple states that I've worked with in the past year that have said, we do not want to stick with standardized measures. We want to innovate and we want to introduce new measures. And I'll describe a couple of those states a little bit later on. So there's, I think, increasing awareness of the benefits of using standardized measures and aligning, but there's not a lot being done to move towards it yet. So let me talk about how other states have approached measure selection. And we've worked in multiple states and with regional groups on measure selection processes. I want to draw from 4 coordination of care measures. And I'll note that in our buying value study, we found that this was an area of particular homegrown measure development and state interest. There's lots of interest about coordination of care, not a lot of easily accessible or for many measure set developers attractive options. Although there are coordination care measures that exist, many of them. They're also interested, in the case of Colorado, in measures of social determinants of health. That's pretty non-traditional interest for a health or healthcare measure set. And they specifically said they want to include creative non-standardized measures. Second example is Oregon, also a Medicaid program. They have two measure sets that are largely overlapping but not identical. Their measure sets were implemented a year ago. One of them is for accountability for a waiver that the state has with CMS. The other is to form an incentive pool for what they call coordinated care organizations, which are something of a hybrid between a health plan and an ACO. I'm going to focus on the incentive measures for their incentive pool were required by CMS as part of their waiver, and their process was to use a formal state staff committee with a committee representation defined in statute by their legislature. And so they had representatives of both the coordinated care organizations and some health services researchers to identify measures for the incentive pool. They wanted a representative set of measures to cover the array of services that are provided by the CCOs and by the Medicaid beneficiaries served by them. They wanted the measures to be valid and reliable. They wanted to use national measure sets whenever possible. However, they also had an interest in the transformative potential of measures. And so the chair specifically said, we don't want to restrict ourselves to tired old standardized measures. We want some transformative measures too. And they also were interested in identifying state-specific opportunities for improvement when selecting their measures. Case example 3 is the Aligning Forces for Quality Alliance in South Central Pennsylvania. This measure set was completed, but they've not implemented it. This was a multi-payer effort to align commercial measure sets for patient-centered medical homes in this region of the state. They had a defined committee that was staffed by Aligning Forces for Quality staff and had participation by key stakeholders, especially health systems and insurers. The participation, I would say, was dominated by one leading commercial insurer and one leading hospital system, with other payers and health systems sort of in and out, and also some sporadic participation by employers. Their criteria, they wanted, again, a representative set of measures across domains of interest. They wanted to align with federal measure sets, and they wanted feasibility. And so that was leading them towards, in the short run, measures that came from administrative data. They had specific interest in aligning with pre-existing stakeholder developed measure sets. So the payers in particular brought their own measure sets to the table and wanted them to be retained. And because this was for medical homes, they were looking for measures that, of course, were relevant for patient-centered medical homes. And then last, Vermont. We have been working with Vermont for about a year now to develop a multi-payer ACO measure set. And that measure set is complete and is being implemented in a Medicaid and commercial ACO pilot that begins January 1st. And their goal here was to coordinate the measure set so that there were as many common measures used for Medicaid and for the commercially insured population as possible. The process was a formal consumer advocates, provider associations, and the state's quality improvement organization. So a representative group, although not exceptionally large, that met pretty intensively. And when I mean pretty intensively, the meetings started last winter monthly and then quickly went to 2 meetings a month. One for an hour and a half and the other one for, I can't recall, 2 or 3 hours. They, again, wanted representative measures across the array of services to be provided. They wanted NQF endorsed measures, and they wanted relevant benchmarks whenever possible. So if you want benchmarks, it's going to lead you towards EDIS measures because those tend to be the only measures that have national or regional benchmarks. They had some unique interests. They wanted to align with the Medicare Shared Savings Program. They wanted to align with HEDIS. As I said, they wanted, actually I didn't say this. When selecting measures, they wanted measures where there was notable opportunity for improvement specifically for Vermont. So if they were performing well on a measure, then that measure was removed from consideration for their ACO measure set and replaced by another measure that might affect fewer patients or fewer citizens, but for which there was greater opportunity for improvement. And then finally, they developed multiple categories of their measures. So they have measures for payment, measures for reporting, and the reporting and payment measures together comprise their core measure set. They then have systems measures. These tend to be measures where state performance was very high, so they're not measuring the ACOs on those measures, but they are having the health plans track their total population and Medicaid report at a total population level. They've got a set of utilization measures that are for descriptive and not value purposes. And then finally, they have a pending measure set. These are measures that they judged as not ready for prime time, but for which there's interest in introducing them in the future. So let me pause for a second because I've covered a lot of content before I start talking about potential policy decisions. Do you have questions about either the buying value study that we did comparing state measure sets, or about anything that Colorado, Pennsylvania, Vermont, and wherever I left out, what any of the 4 states used? Ted told me you were going to have a lot of questions.
You lied. Any more questions while we're waiting for Frank?
I do have one, Michael.
Sure, Frank.
In the Vermont example, you talked about the state-specific measures and those that the state was performing well on, they eliminated. Was that the case for, what about scenarios where the state was performing well, but individual systems weren't performing at the state level?
It's a great question. They didn't have enough data to judge that. So they had no ACO level data. You have a much richer data environment than they do. All that they knew about baseline performance was what the commercial health plans were reporting and what Medicaid could report for just a few measures. So based on that, they said, look, if overall we as a state are at the 90th percentile nationally, we're going to keep tracking that measure through the health plans, but we're not going to measure at the ACO level. Now, it might be the case that if they did ACO level performance, they would find that there was significant variation and that some should improve on that. And perhaps in the future they'll be able to do that measurement, but for year one, when they were trying to decide which measures they wanted the ACO to focus upon, they used the commercial data, which I'll describe as the health system, the state health system data to prioritize.
Katie?
are the measures that are being developed in those four systems intended for public reporting?
You probably couldn't hear that question, Michael. It was the.
Yeah, are they intended for public reporting?
Yes.
I'm not sure what Colorado is going to be doing. I know that in the case of Vermont, that they intend to make the data public. I know that in Pennsylvania that they said that they were going to make the information public. And Oregon. Oregon makes everything public. All their data they put online. So I would say three of them certainly have plans to do so or are already doing so. The fourth one, Colorado, I don't know. Now that being said, making data available online and doing the type of consumer-oriented reporting that you guys have been doing in Maine are two different things. And I would say that these other states, or in the case of Pennsylvania, the Aligning Forces for Quality, that by and large they have not developed as sophisticated mechanisms for conveying consumer information. The exception is the Aligning Forces for Quality group in South Central Pennsylvania, where they have already been doing consumer oriented reporting.
Mike, Tom Hopkins. In Colorado, and maybe to a lesser extent Oregon, but it sounded like it was really kind of a state agency, state-run, just looking at, well, I got the sense that it was more like Medicaid kind of measurement rather than partnership in an attempt to roll it out, including the commercial. Is that right, or am I misunderstanding that?
That's right. That's certainly true in Colorado. In Oregon, they are a little bit post-implementation trying to do that. They currently have a work group involving Medicaid and their commercial payers who are trying to develop an aligned measure set. I think the reason they didn't do it in Oregon is they had a federal, $3 or $4 billion waiver that they had to implement, and CMS was telling them you've got to get your measure set up by 1/1/13 or else. And so they proceeded trying to do some alignment with their exchange, but that was about it. And only now are they trying to align with the commercial payers. Vermont stands in contrast. They were shooting for alignment right from the get-go.
Michael, it's Frank again. In the Colorado example, are they finding it to be a challenge to bring the commercial sector into the discussion after Medicaid has already established its measure set?
In Oregon, not
Oregon,
Frank. They're not far enough along where they're at the point where they're trying to negotiate and trade off on measures. I think that they will have challenges, in part because they've got CMS playing Big Brother there, because when they took all the federal money, they sort of had to sell their soul a little bit to CMS, and CMS actually dictated a couple of their measures in their incentive pool. They said, no, we don't like those, put these two in instead. So I think that they will have challenges if they come back to CMS and say, look, it makes sense for us to align and we want to change our measure set. They could have issues there. They also in Oregon have an issue similar to what you've got in Maine with a lot of national commercial insurers. And national commercial insurers have a harder time agreeing to state-specific measure sets because it goes against their business model, which is to achieve efficiency through standardization. So I think Oregon is going to have challenges both with CMS and with their commercial insurers in time.
So that was actually hits right on what I wanted to follow up on. So in Vermont, we've got that more of a partnership going. And exactly the point, you've got large national insurers that don't want to, have a different measure set for every state. So, do they have more regional players working with them, or?
So Vermont has 3 insurers. They've got Blue Cross plan. They have MVP Healthcare, which is 99% New York State and a little bit Vermont, a little bit New Hampshire. So not a national plan. And they've got Cigna. And the commercial pilot being implemented in Vermont is being implemented for all of their exchange business. And the exchange in Vermont, for those who haven't followed it, the exchange in Vermont is their entire individual and small group market. It turns out that Cigna is not competing in that market. So Cigna would have been the top partner to get to cooperate, but it wasn't an issue because Cigna is not selling any products on the exchange. They are only doing large group and self-insure at the state. So they really just had to get 2 insurers, Blue Cross, whose entire business is Vermont, and then MVP. And MVP was willing to play along and to be a partner at the table. And so it was collaborative and easier than having to work with 3 or 4 national insurers, or in your case, 3 national and 1 regional.
Thank you.
Yes.
Hi, this is Wanda. It sounds as though there's some great opportunities with trying to focus in on some standardized measures that already exist today and it can be comparable between states and with national data. But from the work that you've done with these other states, are there some advantages to using more of a homegrown measure where it's not going to be so comparable between other states and national data, and has any innovative conclusions come from measures that haven't been so standardized?
So Wanda, you faded out a couple times. So Ted, could you summarize her question? Because I missed part of it.
No, but Frank can, he's closer to the phone.
What Wanda asked was are there advantages in having a reliance on homegrown measure sets when you're in an environment such as some of these states where they're dominated, like Maine, by the larger national insurers?
Well, I would imagine that it's easier to sell standardized measures on national insurers than to sell a homegrown measure. I don't think there's any question about that. You're probably easier to get buy-in because the standardized measures, they are already generating to the extent that you're asking them to generate it. And that's a little bit of a leading comment, because when I get on to the next section here about policy decisions, there are questions about what's the source of the data. But the extent that the insurer is the source, if you could ask them to generate something that they've already programmed and they're already generating, then it's easier for them to say yes.
Is that the general?
Yeah, and if there is anything meaningful that have come out of measures that have been tracked that have not been so standardized that we might consider in our own state.
I lost
The follow-up to that one, Michael, was has there been any experience, any beneficial experience for those areas where they have relied on more non-standard measure sets?
I think so. I'll give you an example. In fact, I was just in Oregon last Thursday, and they developed some specific measures. And I'll give you a concrete example. Now, it's a Medicaid example, but I still think it's a good one. They wanted to improve the percentage of kids on foster care who were having developmental and behavioral screens in a timely fashion. These are super high at-risk kids, improve linkages between their state welfare agency and their CCOs in order to get the kids screened. And their performance has improved remarkably because they created the measure, and also because they tied some dollars to it.
Any
Any
other
other
questions?
questions before I move on?
Any other
Okay.
questions?
Is anybody online going to go to meeting, have any questions they'd like to ask? Because I believe they could be heard through the speaker system.
I guess we're all set, Michael.
Okay. All right, so I want to identify what I think are some key policy decisions that you'll want to be thinking about. This is just based on our experience working in other states. So I've got 6 of them identified here, and I'll go through them one at a time and let you know how I see them. First, whoops, didn't mean to go there. First question is, how do you intend to use the measures? Or, measurement to what end? Some measures are more appropriate for some purposes, and not others at a particular point in time. And so I think that before you start saying, well, we want to measure this and not measure that, you need to think, well, are we measuring to see whether we hit some goals or expectations? Are we using measures for payment, either to qualify someone for payment or to modify payment they're going to receive? Or do we want some measures that really are observational and not evaluative? And you come to different conclusions on the appropriateness of a measure based on your intended use or uses. And I think Vermont developing multiple categories of measures reflects the different uses. And I think also with respect to their pending category, the readiness of the measures to be implemented. And I know from conversations with Ted Frank that you've had some, or at least they've had some conversations about potentially different, maybe nested groups of measures. But the utility of the measure is important to keep in mind as you're evaluating measures for inclusion. I'll also note, and you probably know this from other measure work, but whatever measures you select, you have to constantly reassess the measures for lots of reasons. One is because clinical standards change all the time. So cervical and breast cancer screening are just 2 recent examples, but the other one, the recent one is a new statin guideline. So as soon as you develop a measure set, you find that you've got a measure that doesn't represent clinical consensus anymore. In addition, some of the measures become problematic upon implementation. That's especially true with the homegrown measures. But even non-homegrown measures or standardized measures, there will be implementation issues. For example, ICD-10 is being implemented this October. No one really knows what the implications of a large expansion of new codes is going to be for interpreting long-standing measures and comparing performance to benchmarks. So this is a garden that needs constant tending. Second issue to consider is standardized versus innovative measures, and I've talked a little about this. There are many strengths of using standard measures. It facilitates measurement so much. I have to tell you that Oregon picked a few what they call transformative measures, and they've been difficult to implement. They've run into lots of issues, and some of the measures really, they're still working the kinks out as they go into year 2 of using them. But the shortcoming of standardized measures is they may not be assessing what you think is most important. And there are some people who believe that we're measuring lots of wrong things right now, that we don't have measures that are as patient-centric as they should be, that we're not doing a good job of measuring continuity and coordination of care. And so have a more patient-centric assessment of quality, then that leads you to do more survey work. Clinical data is the newer measurement frontier, and within all the states where I've been doing measure work, the discussion is at what time and at what pace to introduce data that's not collected by the payer through claims, but rather is transmitted directly from the provider from its EHR through the State Health Information Exchange. And in both Oregon and Vermont, there are requirements of their CCOs or ACOs to begin to report clinical data for a limited number of measures from their EHRs. And I think that we're going to see an explosion in measurement that's going to be EHR-based. Unfortunately, that's going to mean that the problem of non-alignment of measure sets is going to get worse because the universe of potential measures will grow once EHRs become a reliable source of measurement. Now, how long that's going to take before it's reliable, I can't say, but it certainly is a new source of performance measurement that that measure sets are beginning to tap into. So I've listed the pros and cons here. That clinical database measures allow the opportunity to look at certain clinical processes and outcomes that claims generally don't capture, but it requires sophisticated and accurate data capture by lots of EHRs, or a resource-intensive chart audit, which hardly anybody wants to do, but which the current Medicare Shared Savings Program ACOs are doing. Claims-based data, that they are much easier to generate, they are cheaper, but they only allow for certain information to be provided and not others. And then the survey measures, it's the only way to hear what the patient thinks, but they are expensive. In terms of clinical data, in both Oregon and Vermont, an issue has been, so is it electronic capture or a sampling methodology? The electronic capture is where everyone wants to go. I can share with you that in Vermont, they told the ACOs for the first year that for the few clinical database measures they have to report, they can either pursue a sampling approach, which is consistent with what Medicare is doing with the ACOs, and sample 411 records for both their Medicaid and commercial business lines, or they can report EHR data. And for the first year, if they want to report EHR data to meet this requirement, they had to do so for those primary care practices that together represented 50% of their attributed lives. Now, it so happens there are two large systems that have EHRs in Vermont that potentially could report just for their practices. And so this idea of setting an initial threshold that might rise over time is the approach that they're using in Vermont. Oregon, for the first year, requires that their CCOs submit a technology plan that explained how they would implement clinical data reporting in the second year. The next issue is whether you want to pick measures that you think are important or measures where you have opportunities for improvement. So, for example, you might say, well, we want to track childhood immunization because that's an essential component of well care for children. Or you could say, our rates are so high in childhood immunization that we don't want to measure it. Instead, we want to focus on another measure. chlamydia screening because we rank below the 25th percentile in the United States. So I think balancing what's important in terms of population impact or representing a key domain of population health or a key patient population versus where the opportunities for improved performance lie. There's a tension that lies there, and it's something that you should talk out as you're thinking about how to develop the profile of your measure set. And then there's the issue of aligning your measures with other programs versus having measures that are specific to your program. And what I mean with a program, by that I mean, do you want to align measures for ACOs with measures for medical homes and with health plan measures? Or you want to say the measures that we want to be using for ACOs are really different than what other people are doing, and so we don't want to have them aligned. I think that the alignment helps get everybody focused in the same direction. But your trade-off is that you might not always be addressing a priority that you've got for a program. But if you're very program specific, then you're fostering some measure chaos. And that's just it's a tension that exists when you look at your measure. So I would encourage you to think about not only what might you want to use for ACO measures, but what are the measures that Maine Care is using, and what are the measures that Cigna and Harvard are using in their own contract arrangements. Trying to map out what everybody's using, I think will be helpful and informative. It won't make for easy decisions, but I think it will be an important consideration. So, questions about any of these policy decisions? Comments?
I've got one question, Michael. You noted the Oregon and Vermont models as they've been using some of the CMS ACO measures in the commercial market. Are there any other examples of in other markets where they have tried to apply those clinical CMS measures into the commercial sector?
Yeah, so let me comment to that. So Oregon actually did not consider the Medicare Shared Savings Program measures at all. Vermont did, and they did so, not surprisingly, at the encouragement of the ACOs that were participating in that program. But they used the ACO, Medicare Shared Savings Program ACO measures only to the extent that they lined up with commercial or Medicaid population. So if there was a Medicare measure that they came from an NQF endorsed measure, and the NQF endorsed measure was for ages 18 and up, and Medicare said, well, we're going to use it for 65 and up, then Vermont said, well, we'll use that measure for 18 and up. But if there was a measure that Medicare was using for which the NQF specifications were 65 and older, Vermont did not use that measure. Meaning they didn't say, well, it's 65 and older, but we're going to change the age parameters and bring them down to 18 or to anything less than 65. So Vermont only used Medicare Shared Savings measures where the original measure was appropriate for a commercially insured population. So they wound up using some of the MSSP measures, but not all of them. And that seemed to be agreeable to everyone in what was a very much negotiated consensus process in Vermont.
on the issue of innovative measures, as reluctant as we might be to look at those, have you seen any experience where behavioral health measures in particular have gone down that path?
Yes. Oregon decided that they wanted to have an expert measure. Anybody know what expert is?
No.
No?
Oh, well,
So,
our main care specialist does, but not the rest of us.
okay, so it's a screening and referral protocol for substance abuse. And there is no expert measure that exists. And so Oregon decided to create one. I could say they're a year into using that measure, and they still haven't figured out how to make it work. So my advice would be that if you want to try to develop a measure to fill a hole that exists in the national measure sets, and there are holes. I didn't share a graph with you from our buying value study, but there were certain domains where there were more homegrown measures, and those clearly represented where there are deficiencies in national measure sets. And behavioral health is probably one such area. My advice would be that if you want to develop something new, spend some time developing it and testing it before it becomes a publicly reported measure, and certainly before it becomes a measure that's influencing payment in any way. And test it, validate it. It might mean that it's going to be a year, maybe even 2 years before it's ready for prime time, but I think you'll be better off for having done so.
So you're suggesting a report only for a period of time before you can, in order to establish some reliability and credibility?
Yeah, I think so.
Right.
I mean, measure development is difficult work, and the measures that have all passed through the NQF gauntlet have been measures that have been subjected to a lot of testing. And I think you need to recognize that any new measure is going to need a testing period.
Michael, we have a question from Chrissy Harden.
Michael, how did these states develop providers to adhere to these measures or agree to these measures?
I'm sorry, how they develop provider what?
Adherence.
Adherence to evidence-based as these are valid measures. I mean, we have providers all over the state who disagree on the HEDIS measures.
You're speaking specifically to the homegrown measures?
Yes.
Well, in all these cases, there's a committee, a group, that's developing the measures, and there are provider representatives that generally sit on the groups, although Colorado not yet, but the others always have provider representatives, and they talk it out at that group level. Now, that doesn't mean that the representatives sitting on the group represent, the concerns and opinions of the entire provider community. They don't. But in the case of Oregon, they did have a bunch of physician representatives sitting there who agreed that they needed to develop some new measures in new areas. And so it was by their consensus that the measure was adopted. Now, were there people not in the room who were unhappy with the decision? Yes, there were.
Any other questions before Michael moves on? Oh, yes, Katie.
I was very appreciative of the distinction between measures that you're using for performance improvement versus measures you're using for payment. And interested in whether you have any parameters for making that distinction, and sort of the parameters of what the measures, which measures should fall into which buckets. Are there any criteria that you use?
So I didn't catch all this. So it's measures for QI versus measures for payment. Was that what you were asking?
Yeah,
Yes.
and
Sorry, Frank.
yeah, how do you distinguish between those two categories? Are there any criteria that you're familiar with as to what's really relevant for a QI and what's applicable for payment contracting?
So the measures that are used for payment are certainly measures where people want to feel confident in the validity and reliability of the measure. In most cases, something that's newer and not tested would not be made a payment measure. The payment measures usually also need to have denominators that are large enough that you can feel confident in the rate that's generated. The payment measures these things are always negotiated. But ideally, the payment measures are connected to areas where there's both opportunity for improvement and the ACO or medical home or whatever the accountable entity is has significant influence over performance because nobody likes to be held accountable for something for which they feel that they can't control the outcome. So the payment measures should be subject to considerable influence, in this case by the ACO, if it's to be used there. So those are a few thoughts on my part, but the results that individual groups reach usually reflect the parties who are in the room and how they negotiate and compromise with one another. I also know, another consideration in terms of what's payment and what's not is how does the payment methodology work? And the structuring of the payment methodology might change someone's perspective in terms of whether a certain measure should be included in a payment measure set or left out of a payment measure set.
We have another question for you, Michelle.
Just a quick question. If you have a recommended source for determining what an adequate denominator size is.
Frank, I'll need you to translate it, guys. I didn't hear anything.
Yeah. The question was, do you have any references or sources as to what an appropriate or viable denominator would be?
There are multiple answers I can offer to this.
Give us the best one, Mike.
Yeah, I don't know what the best one is. I have enough humility for that. I'll note that NCQA will say if you've got a sample of 30, that's okay. For the MSSP measures, it's 411. That's eventually you'll have to make your own call. I can't tell you what's right. I certainly would feel better about a denominator that was several hundred, though, than one that was in the tens.
Yeah. Any other questions before Michael moves on?
Do we want to ask the people on?
Yes. The folks who are on the GoToMeeting, do you have any questions?
The question of roll-ups or composites, if you take your 500 measures and say you get significant alignment and you get down to 100, you still have 100 measures. And while it may be really useful for systems for, improvement in targeting areas for specific, initiatives and so forth, at the end of the day, if you have to measure quality, overall quality trends, payment, and so forth, others, consumers, purchasers may need composites. What do you see? Any insight into kind of how that's done, or is it just all over the map as well?
So, I think I showed earlier, when we did our buying value study, I think the average measure set size was 29. In my experience, it's usually somewhere between 15 and 35 are the measure sets. I think that it makes sense to start with smaller measure sets and to let them grow over time. I'll note that in England, I think it's laughable how small our measure sets are because they have huge measure sets, and different measures apply to different parts of the health system. Most of our measures are, at least right now, very focused on primarily the responsibilities of primary care practices, and we don't really have measures that we're applying in accountability systems for ACOs that extend much beyond them. Sometimes people have got some hospital systems across Massachusetts, and their AQC contracts have a whole set of hospital measures. But anyhow, all that being said, I would start with a measure set that feels manageable for the participants, but with the expectation that the measure set will grow over time, because the measurable measure set will also in no way be representative of the services and the needs and the priorities of the population and of subpopulations. So for Maine care, there are all these special subpopulations that are served by Medicaid, and to focus just on, say, chronic illness and preventive care measures, and not focus on the many subpopulations of persons with disabilities, means that they're not measured and forgotten, and that's the problem. But you have to walk before you can run. So I would start with measure set that's in the 15 to 35 range. Not make all of them payment measures. Nobody or hardly anybody has a payment measure set that's that large. And have a process for annually reviewing the measure set and making those modifications and discussing additions to the measure set.
Any other questions from our, we have another one?
This is Dennis. Can anybody hear me?
Yes, we can, Dennis.
We just talked about, Michael just talked about payment on a measure set, and I think that's an important principle, that someone being paid on the performance on a specific measure set, not on being a good provider or a bad provider or a superior provider or a less superior provider. And somehow we've got to figure out how to do that.
Chrissy?
Yeah, I just wanted to get clarification. When, Michael, you talked about the collection of data and how many of these organizations were doing it either through their EMRs or hand chart audits, and I know how painful that is. Did any of these states utilize their health information exchange network, their federal or state network, to start collecting data?
Not yet. They're all still building infrastructure, but they're in varying degrees getting close to it. So Vermont is very close to being able to use their health information exchange to be able to collect data and actually to facilitate analysis of data as well. But some of the other states are further away from being able to do it, but all of them are anticipating that that's going to be the means by which they're going to gather measurement information in the future. Now, I'll note that while this is very tempting, the viability of having electronically transmitted data depends upon the accuracy with which it is captured within the EHRs. And accuracy of capture is really dependent upon proper programming of measures into EHRs. And if they're not properly gathered and calculated within the EHRs, then whatever's transmitted over the health information exchange doesn't mean anything. Should I go on, Frank?
I think we're ready to move on. Yeah, thank you, Michael.
Here's some thoughts on what you might do next. I think, first off, you want to identify what your process is going to be for developing your measure set. So, is it a big table of lots of people? Is it a small table with fewer people? Who are the people who sit at the table? Are they making recommendations to another body? Are they making decisions themselves? All that process needs to be worked out, including what's the timeline and how frequently is the group going to meet. I do think that you want a timeline for when you're going to finish, just so you've got some discipline for your process, which can last for a long time, and a work plan with deadlines. I think that you want to be clear on your goals and objectives for your measure set. That's in the plural, because I think I've indicated that there are many uses for measures in a measure set, and some measures will be more appropriate for some than others. So, a priori, if you can identify what you think your goals and objectives are, and maybe even identify what your separate measure sets might be, that's probably a good idea. You might come back and revisit it and change some of those decisions, but I think that will help structure your activity. You'll note that the 4 states that I cited, including the A for Q Alliance, they all identified selection criteria for their measures at the beginning of their work. I think that's a good thing to do. Then I would use your measures library that has all of the measure sets currently in use in Maine or being recommended for consideration, and consider that as a starting point for your discussion. Now, you may then want to look at that measure set and say, relative to our objectives, what's missing from here? Where are there holes? Are there not enough behavioral health measures? But start with your big crosswalker library that has all of the measures that are currently on the table, so that you've got a place from which to begin without limiting yourself to those measures. I then begin to apply your selection criteria to remove measures from that what I'm calling the library, and begin to whittle down your measure set until you can agree upon a draft measure set. And that whittling process is time intensive, because every measure has somebody who wants to champion it. There's benefit in having different voices at the table to speak to those measures, but there's also going to be a real need for an understanding that compromise has to occur, because otherwise you'll wind up with 75 measures if you want everybody to be happy, and then nobody will be happy. So there needs to be an understanding that compromise to drop the measure set down to an acceptable size, or at least the beginning, is important. And then after you've got a draft measure set, hold it up against your program goals and objectives, and make sure that it stands up, and make adjustments as necessary. So that's what I suggest for a process. Sounds easy. I won't say that it's hard. It just takes some time and effort and lots of thoughtfulness. You'll need facilitated meetings. You'll need staff work to prepare for each meeting, so that you've got the information that you need. So, for example, some of that staff work might be assembling baseline data that shows how either the whole state or how the existing ACOs are performing for both commercial and for Medicaid, so that you're informed. As I said earlier, the measure sets will not be static. They will need to change regularly, and hopefully performance will improve, so that you'll be able to say, well, this measure we're just going to track and make sure it doesn't deteriorate, and we're going to introduce something new. Because I think that's got to be the objective in all of this. It's not so much to evaluate who's good and who's bad as it is to try to inform and motivate improvement over time pause again to see if any of you have any last questions on anything that I've covered this afternoon.
Any questions from the group here? Any of the folks who are on the go-to-meeting line?
Question to Michael again is, Dennis, did any of these groups make a decision how the measures were going to be used before they chose the measures? In other words, are they going to be used for public reporting? Are they going to be used for payment? Are they going to be used for tiering? Or was it just left till a later date?
They generally identified a candidate measure set, and after they did that, then they began to identify which ones would be used for payment and which ones would not. So it was a process.
Yeah, so if there was a measure that people thought was not appropriate for public reporting, they would still put it in the measure set, realizing that they would not report it.
Yeah, I think it's a shaping process where they included all the measures that were of interest, and then they would talk about how should they be used.
Thank you. You've used my time very nicely. I appreciate it.
Any other questions for Michael? If not, thank you very much, Michael. Appreciate it. Happy birthday to your son. And
thank you.
We look forward to having you come up and visit us in 2014.